All right, good evening, everybody, and welcome. You can see the numbers of participants just coming in to join us for this evening's discussion. And welcome also to those of you who are joining us through Facebook or YouTube and able to see the exciting discussion that we have before us tonight. My name is Chad Hughes. I work at the Burnett Institute for Medical Research and Public Health. I work in our international development programs in resource poor settings, and a lot of that work focuses on HIV as the pathogen that my work focuses on in particular. And tonight's forum is put on by Thorn Harbour Health, the community-based LGBTI and HIV organisation here in Victoria, of which I am a past president. So thank you to Thorn Harbour Health for hosting tonight's forum discussion, and this is the fifth in a series, so thank you for putting on all five. They've all been very interesting so far, and I've got a feeling that tonight's going to be super interesting because the topic itself, be a little bit more specific, is very contemporary and of great interest, both to researchers and to community members living with and affected by HIV. Before I go further, I would like to acknowledge the traditional owners of the lands on which everybody is this evening, wherever you're joining us from. For me, that is the Dja Dja Wurrung people of Central Victoria. I acknowledge the elders, past, present, and emerging, and that this land was never ceded, and it still is and always will be Dja Dja Wurrung country. So tonight, as the fifth one in the series put on by Thorn Harbour Health, we're going to be looking at the topic of molecular epidemiology. What is it? What can it do? How might it be applied to HIV? And the way we're going to run tonight is really to bring you up to speed as the audience on what is molecular epidemiology, and we have some experts to take you through that, to come up and understand what we're talking about, and then we're going to have a discussion, a debate with some experts from the community, some expert researchers about how this particular technology or application of a way of doing science could be applied to helping us end the HIV epidemic and transmission of that here in Victoria, in Australia, and possibly elsewhere as well, because we have an international panel this evening. What I will do is introduce our speakers before I ask them their first question, so you get to know who they are. Tonight is very much a Q&A, so for everybody joining us, if you have any questions, if you would like to ask the expert panels anything in particular about tonight's topic, for those of you on the webinar, you'll see there's a Q&A function at the bottom of your screen. Please write your questions there, and we will endeavour to make sure that we get to finding you an answer. And tonight you very much have some of the world's experts on this particular topic, so it's the best opportunity you're probably going to get to ask these questions. But to start off, I'm going to do a little run through and then introduce somebody who's going to give us a presentation to help us all understand a little bit more about molecular epidemiology. So molecular epidemiology, or the ability to track pathogens by genetic sequencing, has been routinely employed in a number of diseases such as Shigella and Salmonella. But to date, this tool is not routinely used to track HIV. Epidemiologists and researchers have argued that this tool would enhance surveillance of circulating strains, transmission sources, and the success of prevention interventions such as community awareness, PrEP, and undetectable viral load. However, there are concerns from some within the community about the deployment of molecular epidemiology that include privacy, stigma, confidentiality, and criminalisation. This forum tonight is really going to examine the uses, potential benefits, and safeguards related to the use of molecular epidemiology as pertained to HIV. Now, somebody who can explain this even better than I can is Professor Deborah Williamson. Welcome, Deborah. Deborah is a clinical microbiologist and Deputy Director of the Microbiological Diagnostic Unit, Public Health Laboratory. She is also a laboratory head in the Department of Microbiology and Immunology. Deborah is involved in the delivery of specialist public health laboratory services and in the diagnosis and surveillance of communicable diseases. This evening, to set the scene, Deborah Williamson will give us a brief presentation on what molecular epidemiology is. Thanks, and over to you, Deborah.
Thanks, Chad. And I'd just like to thank you for the opportunity to come and speak this evening. I'd also like to pay my respects to the traditional owners of the land on which we meet, wherever we are, and pay respects to elders past, present, and emerging. Yeah, as Chad said, what I'm hoping to do is just to give a very brief overview of what molecular epidemiology is, I guess, how we've used it, how it's been used overseas, and to prompt some discussion points. And I'm sure that there will be a good discussion this evening. I just want to start, I guess, by talking about what is genomic sequencing. And, you'll have heard a lot in the media, I guess, or particularly over the last 12 to 18 months, about genomics. So what is genomic sequencing? Well, really it can be described as the study of the content of a pathogen's genetic material, whether it's DNA or RNA. And we look at this, we analyze the sequences, and then we compare them to each other. And that's important, that comparison between data. It means that our analyses they're fundamentally relational analyses. And when we apply this information to the study of infectious diseases, we call it molecular or genomic epidemiology. And again, this is a sort of standard definition for molecular epidemiology, the use of typing methods in the study of the distribution, the dynamics, and the determinants of infectious diseases. And the information that we get can be incredibly useful because it can help us do things like investigate outbreaks, understand the transmission of pathogens, and do things like help identify variants or vaccine escape mutants. And if this is all sounding a wee bit familiar, then I guess that's because we now use genomic epidemiology at a really an unprecedented scale for tracking SARS-CoV-2. And we've now got terms like Delta variants in everyday discourse, thanks to genomic epidemiology. And I guess I'll just want to expand a little bit on that because I guess as a lived experience, this is something that in Victoria we all went through last year. This is how we have used genomic epidemiology specifically for COVID. Each of these lines here represents what we call a genomic cluster. So groups of sequences that are related to each other by that analysis of the genetic code that I talked about earlier. And so you can see here that this section here represents the first wave in Victoria. What you can see is that there are a lot of clusters, and that represents international importation and generally quite limited onward spread. This here represents the second wave. And what you can see here are, I guess, two breaches here in the quarantine system, and this representing that large second wave in Victoria last year. So this is a date along the bottom, and each of these are what we call genomic clusters. That's just, I guess, an illustration of how we have used this in another context. So I guess some of the ethical issues raised by HIV phylogenetic research, and just to be clear, the sequences that we use in this regard are sequences that are generated as the standard part of clinical care. So sequences generated for drug resistance detection and genotyping. And so obviously, as Chad mentioned, there are quite distinct ethical challenges here. But some of the issues raised are very similar that are raised in traditional epidemiology studies. So not even molecular epidemiology, but just old shoe leather epidemiology studies. And those issues obviously include things like the potential for stigmatization, risk of social harm to individuals, concerns about privacy, confidentiality, security of data. But clearly there are some distinct challenges associated with HIV molecular epidemiology. I'll come on to those shortly. Just to say that in the US, these data are analysed routinely now by both state and federal health departments, and the CDC actually have a number of resources. They have a specific section in their website devoted to this with a lot of resources around it. And broadly, they define molecular clusters, so people who are known to be phylogenetic, or sequences that are known to be phylogenetic related, transmission clusters, and risk networks. And that's the way, I guess, that they are promoting the use of HIV molecular epidemiology in not just identifying sequences from individuals that are related to each other, but identifying broader risk networks. Some case studies, I guess, of how this has been used. These are, I guess, maybe very familiar to people on the call. They've been high profile, if you like, case studies. One to identify a cluster of infections linked to injecting opioids. This was retrospective, so a lot of the cases here were already known. And then the other, I guess, relatively high profile use of this has been in British Columbia, where really it was the world's first automated phylogenetic system, which was applied in real time to look at clusters as they emerged and expanded, and to try and intercept them, I guess, before they got much bigger. So there has been a lot of publications and discussions, I guess, around some of the specific benefits and harms associated with HIV phylogenetic analysis. I would say this is a framework that this paper here really provides an excellent framework, I think, for considering the use of HIV sequence data. It's a very balanced paper, and a large working group brought this together. And really they talk about 8 considerations for ethically responsible implementation of phylogenetic analysis in settings where people are looking at doing this. There's also, I guess, this document here, which is an NIH-funded multi-stakeholder meeting. And really one of the important things, I think, in this document was the call, if you like, for further research to actually determine whether this is useful in reducing HIV incidence. And I think that's important. And, you know, against that background, a number of colleagues here and partners put the partnership grant together. So an NHMRC funded partnership grant. And we hypothesized, and that's important, these are hypotheses. We don't know if these will, I guess, hold true, but our hypotheses are that incorporation of real-time analysis may uncover transmission clusters that wouldn't have been detected using traditional epidemiology alone, and that incorporating this data into public health responses may ultimately lead to a decrease in new infections. So these are the hypotheses that we are looking to test in this partnership grant. A number of partners on this grant, and that's obviously critical. And these are the aims of the grant here. And so the first one, I guess, is absolutely relevant to the discussion here tonight, but it's really to develop that ethical framework for implementation. So not just to go ahead and do it, but to take guidance, advice, and feedback to develop this framework for possible implementation. So, Chad, that's my very brief overview, and I'll hand back to you.
Thanks, Deb. I'm sure that's useful to me, but I'm sure useful to many of our participants tonight to get a bit more of an understanding of what it is that we're talking about and what it is that's proposed as well. I think we're at an opportune time in history, as you said, you know, with SARS-CoV-2 and the current pandemic, and people watching it on the news every day. I think people do have an understanding of an application of such technologies to help with contact tracing for COVID. So different to HIV, but at least gives the general population an understanding of what we're talking about. It's also good to see that there's been precedents in other countries where this has already been considered and used. So it's not like we're the first people going out there, and we can learn lessons from others. And I'm thankful that you put up some papers there too, Deb. So I don't know whether it's possible, but people might want to read those papers. If we could get the links up in the chat sometime tonight as well, then people could go and get those papers off, those peer review papers offline, and maybe read them in their own time if they're interested in following that up as well. But you've got your hypotheses, and with all good science, the next step is really to test those hypotheses and see whether they stand true. But as you said, there's those ethical frameworks that need to be defined first. So the process that you're proposing sounds ethical and right, to make sure that if you are going to test those hypotheses, it's done having sort of looked at all the potential risks and either mitigated those or made decisions based on that analysis at the beginning. I'm going to come back to you with some questions later, Deb, but I'm going to introduce our next speaker, who is Sharon Lewin, who I believe is well known to everybody. Welcome again, Sharon. This is Sharon's third time on these panel forums on HIV research and the community. So great to have you back. I'm pretty sure I don't need to do the bio for you, Sharon, but I'm going to do it anyway. Professor Sharon Lewin is the inaugural director. I'll do it. Let me do it. He's the inaugural director of the Peter Doherty Institute for Infection and Immunity, a joint venture between the University of Melbourne and Royal Melbourne Hospital. He is an infectious diseases physician and basic scientist. Her research focuses on understanding why HIV persists on treatment and developing clinical trials aimed at ultimately finding a cure for HIV infection. So my first question for you tonight is, in the context of the HIV epidemic that we're facing in Australia today, why is molecular epidemiology potentially needed?
Well, first of all, thanks, Chad, and thanks for hosting this really interesting topic that is has so many complex issues and complexities around it. It's a great one for discussion and a great pleasure to be on the panel. So we don't know whether we absolutely need it. And I think that's what Deb was highlighting at the end. Other countries are using it and to clear benefit, especially in areas which has a relatively higher incidence of HIV than what we have, say, in the US. So we don't know, which is when you don't know the answer to something, you know, as you just said, that's good science. Ask the question and test it out methodically rather than just doing it, because it may not make much difference. But, you know, in Australia, we've got a very, you know, some success story in reducing new HIV infections, not there yet. A very ambitious target to get to virtual elimination by 2025, announced by the FAO Agenda 2025, a great aspirational goal, which I do think Australia can achieve. And this will be another tool in the toolbox to get there. That's what I think. And instead of just throwing it out there, we'll try and ask this systematically and see if it really does make a difference. All aimed at reducing new HIV infections that couldn't be identified by traditional public health responses. You might argue we've got low infections, we're on the way down, we've got PrEP, we've got testing, we've got information campaigns, you know, we eliminate stigma, all the things we have to still keep doing, treat everyone as soon as they're diagnosed. All those things are absolutely part of the whole package. But will there be additional benefit from this information? And I think also the process of discussion with the community, understanding what this is, having the right systems in place that this can never be used for criminalisation or for means other than what it's intended. They're all good things to have in place, you know, because this will allow us to put this in place. And also it will, I think over time, the concept will be a bit less confronting, because it is very, I mean, Deb is a world leader in this whole area in other infectious diseases, you know, in gonorrhea, in salmonella, in COVID, you know, it's used in a lot of outbreak settings, and it's kind of standard stuff now. But with HIV, it's got a lot of mystique around it. So let's try and break, for good reason, you know, which we'll talk about tonight, but let's try and break down that mystique about this and what needs to be done to be sure that it cannot be used in ways that we don't want it to be used, and that it really can help get better public health outcomes and get us closer to virtual elimination by 2025. I think it'll be another tool in our toolbox.
Excellent. I agree. Tonight's the first, or maybe not the first, but part in that process of really coming together with researchers to really put this all on the table and break down those mistakes and mysteries and questions. You know, it might be a journey to get there, but the more we have dialogue and the more we all talk and we all express our thoughts and our concerns and our aspirations, we'll get there. So it's great to have you here with us tonight, Sharon.
Yeah, I was just also going to say, you know, COVID has brought this language into everyone's home. You know, everyone knows what genomics is, but I think people should, you know, COVID and HIV are very, very different in how we manage that data. And sometimes I kind of get a bit of a, still a little uneasy, you know, hearing about the limo driver and where he works, and, you know, all these details about these people with COVID, you know, like unheard of type of information. I mean, not the name, but still a lot of information unheard of what we would do with HIV. So it is very different, but the technology is the same. Yes.
Sure.
That's really
even today I saw in the newspaper someone's name was published, and it was like, oh, you know, it's a bit of a shock, isn't it?
Yeah, it is. It's still, yeah. I remember actually when last year Peter Dutton got COVID in the US. Do you remember that? And he came back. He said, "I've got COVID." And part of me kind of thought, would be amazing if something HIV was like that. You know, there doesn't seem to be that stigma around COVID. I'm digressing, but I think I just want to reassure people that genomics for HIV is really, the manner in which it would be used is different to genomics in COVID, where it's very, very visible. Yeah.
Sure. All right. I'm going to introduce our next speaker, who's coming to us all the way from the Netherlands in Europe. Edwin. Welcome, Edwin. How are you? I don't even know what time it is there.
I'm fine. It's the morning. It's 10:22 in the morning, so it's all good, and it's great to be here. Thanks, Chad.
Excellent. Welcome. I'll introduce you to our audience. Edwin Bernard is the Executive Director of the HIV Justice Network, a global information and advocacy hub for individuals and organisations working to end the inappropriate use of the law to regulate and punish people living with HIV. Formerly editor of the UK's National AIDS Manual's flagship newsletter, HIV Treatment Update, Edwin also worked for many years as a policy consultant on HIV-related issues that intersect public health and human rights, where his focus was on HIV and human rights, HIV and the criminal law, positive health, dignity and prevention, formerly known as positive prevention, HIV prevention and treatment issues, including treatment as prevention and PrEP, and sexual and reproductive health and rights. He was also integral in advocating for the successful removal of 19A in the Crimes Act regarding HIV criminalisation, which is something dear to the hearts of those over this side of the world in our jurisdiction. Anyway, Edwin, in your opinion, what are the concerns regarding molecular epidemiology as pertains to HIV? Do they differ from region to region, from where you are to where we are here in Australia, to other examples?
Yeah, thanks, Chad. Thanks for asking. And really good question following on from what Deborah and Sharon have already said. So, you know, these new technologies, they're always really exciting, but I think it's really important to understand the context in which they're used, and especially as it relates to HIV, which, you know, is still exceptionally stigmatized. And people living with HIV are still discriminated against and subject to all kinds of unjust punitive approaches, including criminalisation. Just to say, I'm living with HIV, have been since the 1980s. So one of the things that I've been doing, working on this issue for quite a number of years, is highlighting that, you know, people living with HIV, we're not just vectors of onward transmission. And I actually wrote an editorial with a number of colleagues last year around molecular HIV epidemiology called "We Are People, Not Clusters." So just to let you know where I'm coming from. So we do have some concerns, both at the HIV Justice Network and our broader coalition at HIV Justice Worldwide. And they're based really on our expertise and our lived experiences. And in fact, we're about to publish a global review of the human rights implications of what is known in the US as molecular HIV surveillance. And I think the surveillance part of it is a really useful framing of how we're looking at it. And the paper that comes out next month is written by academics who are living with HIV, who are also HIV and human rights activists from Canada and the United States, where this has been rolled out. The thing is, it's been rolled out as a public health strategy without any community consultation. And I think that's where our concerns are the greatest. So it's fantastic that you're having this panel right now. So, and in fact, US-based networks of people living with HIV have actually called for a moratorium of using molecular HIV surveillance when it's linked with public health interventions, because of a huge amount of ongoing concerns, like, you know, public health workers can lack cultural competencies and, you know, maybe racist, homophobic, transphobic, or stigmatize people who use drugs. It can also exacerbate HIV criminalisation, which is rife across the United States and Canada. And also there's these issues of mistrust between public health authorities and people living with HIV. So we hope that our paper, lessons learned from the US and Canada can be used to prevent problems in other places, including in Australia. It's important to learn these lessons. And so here's the main human rights concerns we have been lack of community consultation. And it's really great to see that the Doherty Institute is going to make this the bedrock of their project, because it's really important to listen to and work with all of the affected communities and make sure that the research or the public health intervention not only avoids harming people living with HIV, but that it's actually ultimately beneficial for us. The next issue is around consent and autonomy. So Deborah mentioned that the database, all the information that's used for molecular epidemiology is basically taken from routine blood testing. But whose blood is it anyway? You know, blood taken for resistance testing is, you know, we've agreed that it can be used for that, for our personal benefit, but have we agreed that it can be used for other purposes? Then there's issues of privacy and data protection. And sort of the ideal, of course, is finding that balance between anonymity and data protection, but also to have, you know, those public health and scientific outcomes that we want. And where we really worry is when these data are combined with other available public health or clinical or behavioral data, like demographic data that includes age and sex and gender and sexuality and race, ethnicity and location, as well as information about our behavior or other characteristics. And if they're collected and used without informed consent, I think additional ethical considerations need to be in place. Then there's the issue of that increased stigma on those communities that you're trying to target. And it looks like it's going to be applied to the, you know, historically marginalized and criminalized communities. And in Australia, you're trying to specifically find Asian-born men who have sex with men, heterosexual men and women, many of whom are migrants, transgender people, and Indigenous Australians. And there's a risk that focusing on these identities can reinforce negative perceptions about these communities. Then I think perhaps the elephant in the room is about whether the technology behind molecular epidemiology, phylogenetic analysis, can be used to prove direct transmission. And, you know, concerns about how this might intensify HIV criminalization. The reality is that the tool behind molecular epidemiology can be used for forensic purposes in very specific cases, but that's not the same as the kind of the way it could be used for a public health purpose. And there's a lot of misunderstanding about how the technology used for forensic purposes could relate to how it's being used for a public health perspective. But we need to make sure that everybody understands what phylogenetics can and cannot do, and it cannot definitively prove that one person infected another. It's very clear. There's an expert consensus statement around that. The piece of work that I did that actually brought me into this world of HIV criminalisation was all around that too, and it's widely cited. So those are the sort of overriding concerns, and looking forward to the questions and conversation after this.
Sure, and there's a lot of food for thought there. I'm really glad to have you on this forum tonight, somebody who's, been working with people at the forefront of this in other countries. And as you say, we should learn the lessons of others, and see what has happened before to take that on board. Also, the way that you've been framing and thinking through all the potential issues, it's a lot of food for thought for us all here tonight. Probably we won't get the answers tonight from everything. This is about opening up that discussion, putting it on the table. Yeah. There's going to be some interesting questions already popping up in the chat. And again, we might not get direct answers to those, but the whole idea is that we start to ask the questions. And only when we ask the questions can we start to think about what those answers are. The other thing that sort of struck me in your opening talk there was that it's more than just the researchers and the community involved in this. It's those public health authorities and how they work with community or don't, or how they work with researchers or don't, and they apply, this technology to that use. And it's also the health services and others as well. So there's more people we need to bring to this table in the future than just say the researchers and the community itself.
Definitely.
But somebody here tonight who's our next panel member for me to introduce is somebody who leads an organisation that runs a lot of those health services for the community, and an organisation that is of itself a community-led organisation. Welcome, Simon Ruth.
Hi, Chad. Good to be here.
Good to have you at Thorn Harbour Health Forum, because Simon Ruth is actually the CEO of Thorn Harbour Health.
I know, I'd say thanks for having me, but we're putting this on, so it's a bit pointless, isn't it?
For those who don't know, Simon has more than 20 years of experience in the field of AIDS and HIV awareness, advocacy and treatment, alcohol, drug treatment and Indigenous services, youth work and community development. Simon has worked in both public health and the not-for-profit sector. It's great to have you on one of the Thorn Harbour Health Forums. My question for you at the beginning here, Simon, is what are the advantages, if any, to the community with regards to molecular epidemiology?
Thanks, Chad. And I'm probably going to say less than my co-panelists because they're the experts in the area, and I much prefer listening to them speak than hearing me speak. And I do feel a bit like a minnow compared to them and their knowledge. And I think Deborah touched on this. I mean, the advantages are that we may uncover HIV that we weren't aware of within the community. There may be advantages to people living with HIV if we can alert them to that and get them onto treatment earlier. There may be health benefits for them in that process. There may be benefits in a world of shrinking HIV prevention dollars. I mean, ideally, it would be very easy to get a HIV test in Victoria or South Australia, and it's not. It would be very easy to get syringes, clean syringes and condoms and PrEP and PEP, but it's not necessarily easy to get any of that. So there may be some benefits to people who don't have HIV, because it will uncover HIV in the community and it will stop them from accidentally acquiring HIV as they go about their lives, enjoying themselves or however else they choose to live their lives. What I'm not sure is so there's benefits to people who learn they've got HIV early, there's benefits to the rest of the community who don't have HIV. I'm not sure that there's actually any benefits to people who are living with HIV, who know their status, and are the people who will be providing the genetic material to make this happen in the community. And so it seems that as Edwin talks a bit and talks about the risks, it seems that all the risks almost sit with the group in the population who are going to have the least benefit from this. The risks are going to sit with, the risks of this being misused are going to sit with people currently living with HIV, and they're the people probably going to benefit from this the least. And the first time I ever saw Deborah present on this, she presented on STIs and she put up charts and did one like she did earlier with COVID. And I can remember sitting there looking at it thinking, now I've had those tests and I had no idea that my genetic material was going to be used by someone like Deborah for good purposes. But it was going to, you know, go into a bank and then be analysed, and they'd be tracking who's been doing what with who. And I think when a lot of us go in to get our STI screens and go in to get our health checks, what happens to our genetic material is not necessarily at the front of our minds. Certainly for people living with HIV, they're much more conscious of it because they know the risks and they know the stigma associated with it. But for everybody else, I don't think we are. And so I think there's certainly an education program that has to go along for the community about every time blood comes out of your arm, what's happening with that blood. Or every time saliva is taken, what's happening with that saliva and where's it going and what's happening with it and what are the risks potentially associated with that. So, you know, Sharon said we don't know if there's benefits. We hope there are benefits to this, but there are certainly risks, and I can see they're popping up in the questions already. And so I'll be keen to hear my co-panelists discuss those risks.
Yeah, thanks, Simon. And it is interesting, as you say, the punter who walks into the clinic to get a test, I think the vast majority, if not close to almost everyone, doesn't really understand necessarily what's going to happen with some of those samples, or that they might be stored in a deep freezer for the rest of existence, you know, but they're still out there somewhere in the sample that you gave a long time ago.
Every time you get a HIV test, you got to fill out that long form, and after your first one, it gets a bit boring, and you just, you know, you go on autopilot and tick all those boxes and sign it and hand it back.
As you said, potential risks are not what we're here to discuss, but also benefits. And my next question is back to you, Edwin, because you're coming to us from abroad and you have looked at where, you know, I'm calling it molecular epidemiology tonight, but I'm even becoming very clear in this discussion that there are different terms that are used to describe this particular type of science and application. And we could even have a discussion maybe later about, you know, the power of the term that's used to describe it, whether it's got that word surveillance in there or not, and what impact that will have on community trust, etc. But my question for you first is there anywhere where you think it actually has been applied to date, where it has had benefit, where it has, from the researcher's perspective, added an ability to be able to maybe address some of those things in the hypotheses that Deb put for us tonight?
Well, the technology behind it, of course, has been used in lots of ways that have really furthered our knowledge and information that are benefiting all of us. And I'm thinking particularly the HDP-N052 study, the study that finally basically proved that U equals U. The use of phylogenetic analysis there showed that all of the transmissions that happened in that study were unlinked. So going back to my point earlier, what it basically showed was that the best use of it when you're trying to show did one person infect another, you can only show that it actually didn't. So so it showed that in that study, it showed that the only infections from of partners who are people who are on treatment actually came from outside that relationship. Now that has all kinds of other ethical concerns, but it really helped our knowledge. And so I'd say that is a perfect example of how the technology has been really used successfully. But it really depends on what you mean by success. You know, of course, we know it's beneficial to understand, you know, different viral subtypes, understanding resistance, helping us understand data like, you know, U equals U, but it's the cluster stuff, the transmission networks, the risk networks, even that those names get me on edge a little bit. So, and one of the justifications I think for scaling it up is that it's become really cheap and easy to use because you're making secondary use of routinely collected data, but it's actually that blood that's taken for one purpose, so individual health-related monitoring, and then being repurposed for real-time monitoring for public health purposes. So it's seen as cost-effective and a win-win, but what about the unintended negative human rights cost? Because they're rarely ever considered as a cost. And so there needs to be that balance between privacy and possible benefits. So that study that Deborah highlighted at the very beginning, the first time they ever used that real-time phylogenetics, that's become the basis now for this discussion, that in British Columbia and Canada. So, you know, they found 11 new cases over 3 months, including 8 cases with transmitted drug resistance. And in that cluster, it was basically young gay men and other men who have sex with men. And they were contacted for enhanced public health follow-up to ensure they had linkage to care and started treatment, which involved the public health authorities directly contacting the men and encouraging them, and we don't know what kind of encouragement there was, to seek care and testing. But the additional benefit of using molecular HIV surveillance for that, in that particular case, is questionable, because all of those cases associated with the follow-up, they'd already been linked to care. And in fact, 5 of them had already started treatment. So we have to question whether, was it really as fabulous and as beneficial as it's been made out to be. And then, you know, the reality is that some of the information gained might actually be redundant, because people they've already been identified and connected to care. So, you know, we're using things that don't actually have the same ethical concerns. And then there's like issues around privacy and stigmatizing communities. And there was a study done in Seattle that basically found people who were homeless and who engaged in transactional sex, and also people who used drugs. And you know, they found this cluster, and it wasn't, you know, they couldn't find it through traditional contact tracing. That's great. The problem is the media took this up, and they actually wrote about it in a way that actually included the exact street that these homeless people lived on, which really, that violation of privacy, it could have led to all kinds of things, including violence. So one has to be careful that when presenting the results, that then the media pick up on, that you don't actually do anything that could potentially harm people. And so we've got to remember that the public good, that, you know, public health, actually also involves people living with HIV. We are part of the public, and harms done to us actually can harm the public. So the biggest concern, though, and the largest risk, and I think this is something that you're all potentially aware of, because this has happened in Victoria with an HIV criminalisation case about 13, 14 years ago, is when data is shared with law enforcement. And so any kind of, you know, breach of confidentiality or inadequate anonymization, or in any kind of non-public health use of this data, can cause all kinds of problems, distrust with healthcare workers and the health systems. And in fact, the very first criminal case in Scotland involved someone who was part of a study in prison, a molecular surveillance study in prison, and the police forced the study people to identify who he was, because he was subject to another investigation, and that really, you know, damaged trust between people living with HIV and healthcare. So success is in the eye of the beholder, and so every time that we hear that there's going to be a rollout or a study of molecular epidemiology or surveillance, we need to hear how these results can better serve the lives of the people living with HIV, rather than just being a new shiny technology that may tell us what we already know or risk harming us more than helping us.
Sure. And the message I take from, one of the messages I take again from what you say, is the real-time applicability of this technology, in the sense that in that example you gave, people had already been linked to care and sort of, you know, had moved through the process by the time the data was there to be analysed and to be applied. So it didn't have any impact on that particular chain of transmission or on those people's lives per se. And knowing, you know, for people that occur at that point in time, where there's the diagnoses of HIV coming out, that's the time when they feel the most vulnerable, and probably the least amount of time where they want all of this sort of data being tracked and added to surveillance and trust, that kind of system. So that real-time applicability is, in terms of the benefit, is going to be crucial as well. So the data is not analysed 6 months after it's taken and then blah, blah, blah. And we can go back and look historically and say this is what happened in that particular chain of transmission and cluster, but it didn't help anybody or help stop that particular chain. Yeah, lots to think about there. I'm going to jump back to you, Deb.
Thanks, Chad. Thanks.
And, you know, we're obviously thinking about COVID because that's at the forefront of our minds, and whenever we turn on the TV, we see the contact tracing stories, and we see it in the newspapers, and we know that, you know, these technologies are being used to help us figure out chains of transmissions and clusters and all that kind of thing. Are there any other examples where this technology has been used on different pathogens, perhaps, and have applicability that's helped us understand or make a public health difference in how we address, you know, communicable diseases?
Yeah, thanks, Chad. I really appreciated Edwin's viewpoints. Actually, there are a lot of food for thought there, and you know, the we are people, not clusters in particular. I think it's something that, you know, as researchers working in this space, we have to be extremely respectful of. So I appreciate very much that he highlighted that. I would just say that, you know, this isn't new. You know, linking up a diagnosis, and I'm not just talking about HIV here, I'm talking about infectious diseases more broadly, but linking up a diagnosis with epidemiological information is something that's been going on for years. So if you took the molecular part of molecular epidemiology away, you could look back decades and find published papers where there were epidemiological associations made looking at people who'd been diagnosed with infectious diseases, I guess, linked to different demography, if you like. So what the molecular part does is, I guess, shine a little bit more granularity on that. And I guess molecular typing applied to infectious diseases, or typing, I should say, applied to infectious diseases isn't new either. I mean, that has been going on for decades, whether we you know, give something a species, or we look at I guess an antibiotic resistance profile. They're all ways of typing pathogens, so that's not new. But I guess what we're talking about here is phylogenetic analysis, and I guess that has been applied to infectious diseases and informed public health responses for other pathogens for, you know, the best part of a decade now. You know, for example, in the US and actually here in Australia, genomic sequencing really forms the cornerstone of foodborne disease outbreak investigation, and increasingly foodborne disease tracking as well. So provides critical information on the sources and transmission of foodborne pathogens. And there are some really good examples, I guess, of, and just to be clear, it's very hard to measure prevention in this regard. But there are some good examples of it really shutting down outbreaks early. And similarly in the UK, prospective analysis of genomic analysis of TB has been underway for several years and uncovering previously occult transmission networks. So the spectrum, I guess, of infections covered by genomic analysis is so broad that it really spans the gamut of human interactions, you know, from breathing, like COVID and TB, to eating, like salmonella, and as Simon highlighted, to sexual activities like gonorrhea as well. So yes, it's a short answer. It has been used for other pathogens, It's Edwin's right, success is in the eye of the beholder, but if you're looking at clinical, and in the case of foodborne disease, economic outcomes, then has been used with success in that regard. One thing I would just say is that, you know, this is a relatively new new experience for many clinicians to deal with. But what I mean is that most of the training that we get is how to convey a diagnosis to individuals rather than the relational context of their diagnosis. So put very simply, communication to people around infectious diseases is generally focused on what do I have, rather than how or where have I got it, if that makes sense. So there's the take home from that is that there's a lot of education to be done in the clinical sphere about the meaning and interpretation of those data, in addition to the much wider education that Edwin highlighted very eloquently, you know, to the media and society more broadly.
Yeah, thanks, David. And highlights to me that it has been used very broadly. And as you say, around the education and drawing on what the other speakers have said, I mean, this discussion here is between the community and researchers, which is a very important first discussion, because the community have to want this and agree that there's benefit and agree that, you know, the risks to themselves are not too great and can be mediated. But there's that education also for all the other stakeholders, those public health authorities, the media, even the law enforcement, all the other people who may get access or even request access to this kind of data for their own purposes, around the education that is required and the communication to bring those stakeholders in to understand what they can and can't do with the data, or whether they can or cannot access that data as well. And so looking at those concerns and looking at the chat, a lot of the concerns are around criminalisation and privacy. That's not surprising at all. I mean, you look at the COVID story that's unfolding before us now, and I'm going to ask you, Sharon, you know, we talk about how people's names end up in the newspapers, or I even kind of joke sometimes to myself and friends, it's like, you know, my goodness, the contact tracing, if you were somebody who was there, then everyone knows where you've been, because the whole list of all the places that you've been in the last few days pops up on the internet. And that might not be good for people as well. The loss of privacy, I guess, in terms of, even though your name's not linked to those places, people could probably potentially connect it back to you. So it's just an interesting one in terms of this technology that we might use for HIV as well. What safeguards would we put in place, I guess, or what do we need to start thinking about, or we are starting to think about, in terms of making sure that this kind of science could never be used for criminalisation purposes, or to make sure that the privacy of the individuals whose, you know, samples are taken is protected?
Well, I think that we use exactly the same principles we use on every aspect of personal information of any person we see on any medical consultation, I should say. But we have a heightened awareness around it for HIV, but actually the same principles are for anyone, any person that seeks medical care, is that it's absolutely confidential and that information is not available to anyone else. That's it. That's it. We have that whether you're coming with lung cancer or blood pressure or HIV. Now, there's a lot of sensitivities around HIV. When we should also have some perspective around the information we usually gather with a new diagnosis of HIV, where we will, either with the clinician or with health authorities, will slowly uncover contacts that would need to be tested for their benefit. And, you know, that's a process we go through every time a new diagnosis of HIV is made. It's got, at least I know in a country like Australia, it's done extremely sensitively and with privacy at, you know, the absolute forefront of people's thinking, but it needs to be done for public health reasons. And so Have you ever seen the contact tracing details of someone with HIV like we're seeing it with COVID? So I think COVID's a bit of an outlier here. We're not on some road to a new way of managing infectious diseases, because we would never do this with the information which, you know, may be in most cases sufficient. People will tell you who they have had sex with and who they think may have been at risk, and all of that. We do, that's data business and has been for 40 years, and for how we manage HIV. So it would exactly the same principles around absolute privacy of medical information would apply here in exactly the same way. It's de-identified. You cannot access it. If for some reason a criminal case, and I think Edwin actually raised an example from 12 or 13 years ago in Australia, you know, you could try and get that test done anyway, but you know, you protect it in exactly the same way we do with all health information. I should just a couple of comments I was going to say around the terminology. I think it really is important. So this is not the first time. I know there's 30-something people on the call here, but we have had a number of really helpful fora with leaders from community organisations and a broader information session, maybe about 2 years ago now, actually. So this is one of many conversations, and of course many community agencies are investigators on the grant, as are public health officials as well. But we actually did very consciously call it molecular epidemiology, because we would normally do, you know, standard epidemiological contact tracing, standard sort of oral epidemiology. And this is an addition to that process, which is molecular epidemiology. Surveillance that certainly does conjure up a lot of other emotions, I think. And this issue about direction of transmission cannot be determined from molecular epidemiology.
Okay, great. And yeah, that's an interesting and important point as well. Deb, I wanted to come back to you, because I have seen you present something on this before, but it wasn't about HIV, it was about Shigella. And I think it's a useful example to sort of throw out there to the audience, because Shigella is also predominantly, I guess, or can be a sexually transmitted infection. So therefore the same kind of, without the criminalisation aspect, but the privacy concerns are there too, right? And you've used this technology on Shigella and been able to do that in a respectful way that protected everyone's privacy. Did you want to talk a little bit about that?
Yeah, thanks, Chad. Just to be crystal clear, you know, it's, I guess, intuitive to those of us on the panel, but may not. It's worth reinforcing, I guess, more broadly, is that what we're talking about when we're talking about sequences and, you know, genetic analysis, that's not of that's not of you, that's not of the human, that's of the pathogen. So it's not the same as sequencing you, it's sequencing the pathogen. So just to be very clear on that. And so yes, we have, in the same way that we have used this for TB, for salmonella, for pathogens in the hospital, we have used this to look at Shigella as well, and looked at very de-identified data, but linked up to some exposure data. So if you were just to look at the sequence data in isolation, they don't really mean much, but it's obviously when they are integrated with some epidemiological data, that's where they're useful. And we were able to identify, I guess, a number of things. One of them was that people were coming back from their travels with very drug-resistant Shigella, and that there was, I guess, circulation of a very resistant Shigella strain amongst the gay community in Victoria.
Yeah, so to me, that's a good example of a, you know, a pathogen that people might see as embarrassing or something where they wanted their privacy protected, and you have applied the technology, but with the identified data to actually understand what's going on.
Yeah, but just to take that one step further, what that led to, I guess, was some health promotion campaigns around, if you had gastroenteritis, please go and get tested, because the drugs that you're given may not be effective. I encouraged some campaigns around, just making sure, some campaigns around, how to protect yourself. And I also led to, Chief Health Officer advisory as well. So there was some, I guess, public health action.
Sure.
What we weren't able to do was to measure a decrease in incidence, but but certainly there was some public health action that came from those. And that's what we're talking about, right? We're not just talking about doing this for the sake of doing it just because we're, for academic curiosity. It's actually to affect some public health action.
Yeah, that's the point I wanted to sort of get to you with as well, is, so what's the application of doing this with HIV that's going to help us make a difference?
Yeah, and hand on heart, I don't know is the answer. We don't. I don't think anybody here knows whether this would genuinely make a difference in our setting. But that's, those are the hypotheses that we would like to test.
Sure. So that's one of the big questions. What is going to be the benefit, and is there a benefit? I guess especially as we get to the pointy end of the HIV pandemic here in Australia. But as Edwin said, earlier, at the point where we're at with HIV transmission here in Australia now, if we are focusing on migrants and people who don't have Medicare access, and Indigenous populations and those kind of groups, perhaps there are some issues. Edwin, I want to come back to you, really, to garner from your wisdom as well. What kind of safeguards would you consider are bottom line requirements for the community for us to have confidence that molecular epidemiology and HIV is going to be okay? And if you wanted also, I see that there are some questions there in the Q&A that some people have some concerns there around criminal application. You might want to have a go at answering that as well.
Okay, so first of all, look, I don't want to be considered, I'm not a Cassandra, although sometimes I feel like that one. People living with HIV, we want to be part of the solution, but the thing is that we're often seen as the problem. So, we're not Luddites, and we do want new technologies like molecular epidemiology to help end the HIV epidemic, but not at any cost. So I was involved in a study in Brighton, where I used to live, and London, led by Larissa Malka, which was the first one that actually asked people living with HIV and people who tested frequently, what was the acceptability of using phylogenetic data in clinical and public health practice. And the conclusion of that study was that acceptance was dependent on the perceived risks and the public health benefits. And if it was used without addressing certain concerns, which were informed consent, data protections, and benefits to HIV positive communities, there was a potential risk of individuals disengaging from testing or from care. So the bottom line recommendations in this paper that's coming out next month are these. First of all, consult with and take seriously any community concerns and act upon them. So events like this are a fantastic start, and I really welcome the conversation. And I don't think that Sharon and Deborah and I are really that far, or in fact, I don't think we're far apart at all, which is fantastic. And then if you're doing molecular epidemiology, either as a study or for public health reasons, please do demonstrate that it has a clear public health benefit that outweighs any potential harms, and make sure those protections, the data privacy, the legal protections, the social harm prevention are all in there. Then make sure that those benefits do actually benefit us. And please do respect the bodily autonomy and integrity of people living with HIV, no matter who we are, not just well-spoken cis gay white men. Healthcare providers who are ordering HIV resistance testing, please, and those, because they know these data are going to be used in other ways. We think they should inform their patients about how their blood and data are going to be used for surveillance purposes. I'm sorry to use that term, but it's kind of what it is. And allow us to withdraw our consent if we wish, without fear of any negative consequences. So at minimum, we would say an opt-out, but actually, ideally, we would like to see people opt in. Because, as I say, we want to be part of the solution. If we understand that our blood is going to be used in these ways, and we opt into this, I think we'll all feel a lot safer and happier. And then finally, and I know this is also where Deborah and Sharon are, anyone who's implementing this, you should publicly advocate against punitive or coercive laws and policies aimed at people living with HIV, and make sure that any of this data is never used in criminal or civil or immigration investigations or prosecutions. Those are the bottom line recommendations.
Thanks, Edwin. Simon, I'm going to ask you to put your camera back on as well, because we're kind of at a Q&A part of the evening here. Does anyone on our panel have further comments or thoughts on?
Yeah, if I could jump in, and I'm not sure if it's actually been said, and correct me if I'm wrong, Deb, but this can be done right now in Victoria. There's actually nothing stopping. There's no legislation in place that protects HIV from being put through this process. And when we did start these conversations 2 years ago before COVID hit, it was the Doherty who approached us and Living Positive Victoria, Positive Women, and said, this can be done. There's a move internationally to do it. Let's have a conversation about how we can do this respectfully. Do we want to do this? And it was the Doherty who approached the community and said, let's do this before it gets foisted upon us. I mean, we do have a very responsive health minister in Victoria who has said we won't have spitting laws here. He will protect people living with HIV, but it's not necessarily always going to be that way. And we may get a recalcitrant health minister who decides they want to go down this path. So that is the case, isn't it, Deb? It is possible to do right now, and they could tell you that you have to do it.
Yes, yeah, they could in theory, but I think it would be unlikely. I don't.
Yep.
Yeah, in theory, Simon, but I think that would be vanishingly rare. I'm keen to hear Edwin's perspectives actually on the rollout in the US and where you think that went wrong.
Yeah, well, so, I mean, the first thing is that it was announced as the fourth pillar of the epidemic plan, under the previous administration, under Trump's administration, and there was no community consultation. It was, the CDC just rolled it out, and there's huge amounts of financial incentives for state health departments to actually do so. So I think, and what they're trying to do now is shutting the stable door after the horse has bolted, and, are trying to do community consultation, but in a context where HIV criminalization is a real issue in many US states, and, stigma, discrimination, also immigration, basically treating people who are the most vulnerable to HIV in a terrible way. That's been part of US policy, unfortunately, for a very long time. I'm not sure Australia is quite as bad, but you're not perfect either. So I think that, the context is really important. And I know there's been a number of questions asked around different aspects around criminalization in the Q&A, and I didn't really get the chance to go into them. So I'm just trying to look. So, what guarantees do we have that HIV cluster tracing won't have private details released like they were with COVID? I mean, Sharon, you've answered that question, but one of the things that, when I referred to the previous criminalization case in Victoria a few years or more than a decade or more back, one of the thing, I mean, it was a political shitstorm, but also there was the case when the police had a subpoena from the judge to actually get the details of the person who was being investigated. The clinic handed over more case notes, and someone else ended up being prosecuted as well. And I know that systems have been put in place to prevent those things happening again. But the reality is that when it comes to a criminal investigation, a judge can be persuaded to provide a subpoena. So even though there are all kinds of privacy protections, rightfully so, they can be overridden when there's a police investigation if they've been able to persuade a judge to to access to write a subpoena for police to access those things. So, but those are exceptional cases, and we just need to make sure, though, with this data, that communities, particularly people who might feel they want to have access to figure out, can this data show that actually somebody infected me and I now want to go and make a complaint? It can't do that, and that information. There's a number of reasons why it can't do that, but right now the technology is not set up to show direct transmission. It can show direction. It could show who was infected earlier and who was infected later, potentially, but when it's used from an epidemiological perspective, I'm sure you can explain this better than I can. It's only about looking at clusters, because there's always going to be people who are undiagnosed, who are not part of this study, who could potentially also have been part of the transmission chain. So it can't, and that information should never go back to individuals to help them figure out who infected them, just because it's completely unreliable, and I'm not sure it actually helps anybody come to terms with a new diagnosis anyway. I don't, obviously, I advocate against HIV criminalisation for lots of reasons, and one of them is that in the end, involving the police and the criminal legal system doesn't really help anybody come to terms with a diagnosis, and putting someone who is perceived to be a bad actor behind bars doesn't really help anybody, because it's a much larger problem, and ending new acquisitions is a much larger issue and involves all kinds of social issues as well as all the new technologies and access to PrEP and treatment and prevention. So yeah, people who are concerned about use in criminal cases, the project that you're doing has no relationship to criminalization. But the tool, phylogenetic analysis, can be used in criminal cases, but primarily, and I think I said this previously, to exonerate somebody. It can be shown that actually these transmissions were unlinked. And it is being used in cases where transmission is trying to be proved, and it can only be used in concert with a number of other pieces of information, including medical records, who was diagnosed first, all those kinds of information. But that's really not anything to do with the project that you're doing. It's the same technology, but used in a forensic way. I know perhaps Sharon or Deborah just want to confirm that what I'm saying is the case in Australia.
Yeah, absolutely. And I mean, that information is there, because everyone in Australia gets a genotype when they're diagnosed with HIV to ensure they get on the best treatment possible and they're not resistant to the antiretrovirals that we choose. So it's a very important part of care, and it's there as part of someone's medical record. So that information is actually always there. And exactly as you say, you cannot determine directionality. You just know that they're connected somehow, because there could be a third or fourth person involved.
I think you've answered another question that was there in the Q&A through that, Sharon, about can genomics be used to help in pharmaceuticals to do better medicines and preventive vaccines?
There's also a really interesting question here. I think it was the first question on, can genomics explain the difference between HIV elite controllers, or people without, and people with whose HIV infection outcomes are worse than the average? So yeah, genomics we actually do analyze the sequence of HIV for clinical care, which is, as most people will know, will determine if someone has infected with a drug-resistant virus prior to making a decision on which antiretrovirals to choose. So yes, it's very relevant. But maybe the first question was, we also use it to understand the reservoir, or why and where and how HIV persists on treatment or off treatment. So in fact, a lot of understanding of elite controllers, or people that can naturally control their virus without any treatment, and these new, very rare but distinct group of people called extraordinary elite controllers. We use genetic analysis, but it's actually of the virus inside the cell, which is slightly different. But it's telling us a lot about the reservoir and about how people, may eventually be cured.
I think that's an important point.
Yeah.
A couple of times too, that the thing that's being genotyped is not human being, but it's the pathogen, the virus, or
yeah. So legally, like Simon said, you know, like remember actually when we first met, Simon was like, "No, I never asked us about this stuff." But it's quite interesting, the distinction, because human genome sequencing, as you all know, if you know, signing an insurance form or something, there's a lot of legislation around that. But pathogen genomic sequencing, there isn't.
To me, something that's come up from a number of you during this discussion is that there's a need for a lot of education, because these are quite technical concepts.
Yeah.
And it's like when we've talked, Sharon, about HIV cure science in other forums. It's some really technical stuff, right? And so when you've got the community that are either living with HIV or affected by HIV, and you're trying to take them on that journey of explaining technical science in layperson's terms, so that they even have the ability to sit there at the table and feel like they can have a dialogue because they understand the premise of what's being spoken about. There's a lot of work, I think, to be done there with this as well.
Yeah, I agree. And actually, even that whole thing about telling a doctor you exactly what tests they're doing, many doctors actually don't do it. HIV really changed that whole concept. Because remember that at the very beginning, you know, you're testing for HIV and you had to be properly trained and you had to have consent, and it really changed the way. But the whole, it's crazy that you could just order whatever test you want and not explain what you're doing to the patient. But it's really important thing to ask, you know, what's actually being tested. And you know, some doctors will go through each what they're looking at, but it's kind of not part of standard practice. It's some area for improvement.
Yeah, exactly. I mean, and even if they are explaining it well, it's likely that the person who's sitting before them is not comprehending, or even if it's at the point where they've just been told their HIV diagnosis, I'm sure they're definitely not comprehending anything that's being said to them from the doctor after that. They're just sitting there in a sort of stupor state and not able to comprehend what the next part of that conversation is. I wanted to ask about something that Edwin said before around opt-in or opt-out. It seems to me, and I'm no expert on this, I'm asking you, Deb, perhaps, or Sharon, is an opt-in model even feasible in terms of working for this kind of science? Because you kind of need all the samples, right, to be able to join the dots and the nodes and understand what's happening. If you've only got a few people who are opting in and then there's a whole lot of people who aren't, you're not getting perhaps the level of data that you need to be able to make benefit of it. Is that correct?
Yes, I mean, you know, again, more broadly applied to other infections, you know, foodborne disease, for example, we're only really seeing the tip of the iceberg anyway. And just to be clear, I think there's a question about we can infer direction of transmission of foodborne disease. We can't do that with any kind of genomic analysis. We can infer, or we can, again, hypothesize, and we can look at associations, but we can't, no matter how fine scaled the analysis is, we cannot say definitively, you know, that person gave it to that one, or you got your salmonella from that place. We can't. So we look at everything critically. We look at all of the evidence and you know, and make an association then. So just to be clear, just to address that question, we can't even do it for foodborne disease.
Yeah. And that's very important to know as well. I think that's part of that education for the.
Yeah, look, in a way, you know, the technology and the people using the technology are and inappropriately probably well ahead of the education around it, right? And that's you know, there's a lot of there's a gulf, I guess, to address there. Opt-in, yeah, it would be tricky. Yes, it would not give you the whole picture. And I mean, I don't want to make off the cuff and ill-considered comments about this now. I think it's something that would need to be thought through as to how it could work. Sharon may wish to comment here, but yeah, it's an interesting thought.
But some of the things that give me confidence through this dialogue, one is that the Dawati are doing your due diligence here in terms of consultation, not rushing things, taking time, consulting over a long period of time, trying to make sure that everybody has a chance to sort of put that discussion there. And you're looking at all of these concerns, and I like the way you said before, Deb, we don't just do this for the thrilling science of it and the mystery of sort of answering the questions, and because it's an interesting piece of science that's going to tell us an interesting story. You're only really interested in doing this if it's actually going to have applicability that's going to make a difference.
Well, yeah, that's
in the epidemic or in people's quality of life and linkage to care, right?
Because the technology, I mean, Sharon mentioned this earlier, the technology now, it's not new. It's not, it's not the cutting edge technology anymore, but it's about the implementation of it and whether or not it's useful. And that, and again, it would be arrogant of me to say, yes, it is useful without doing studies like this to actually assess whether it is useful, and not just applied to HIV, to other areas as well.
Yeah, and also we are in quite a different situation in Australia to other places where it's been used, with a very different and ambitious goal about elimination, which is a great thing. So, not saying that this will make a difference. All the other stuff has to be done, but this will be an added piece to the
tool in the tool belt.
Yeah.
Exactly.
The education is really important here, and Simon might want to chip in here, but I was recently involved in, I would say, a relatively inglorious media interview where I was asked about the use of genomics for syphilis, and I had what I thought anyway was a very nuanced discussion with the reporter around some of the complex public health drivers of syphilis, and really the conversation again I thought focused around ensuring better access to testing and treatment for syphilis, but that was not the top line in the article. And Simon very appropriately drew attention to this, and so I think that the broader education and consultation with the community before studies are released, even to preempt that messaging, is important. Simon, do you want to comment on that?
Look, just to say, it's happened to lots of people before you, Deb, and lots of people after you. And we all know now that newspapers like to talk about gay men's sex lives and how we use drugs. And it doesn't matter how useful the piece of research is, they will always focus on the titillation piece. So we need to be really careful about the language we use, because you screw up one word and that is what the journalist will target. We've all been there.
Yeah, and as we've discussed tonight, I think that it's important to take all those other stakeholders on this journey with you guys, the Dawati, as well, like the media, and law enforcement, and everyone else who ears might prick up when they hear about such a study and start to think about how it might work for them. Remembering these days with COVID, everybody is an epidemiologist, right? Everybody is an expert on what we should be doing from a public health perspective based on the data. So everyone's going to have their
and in an age of clickbait media, that's where journos go.
And yeah, I mean, and I would just say, obviously the example, you've already had these examples of if not naming and shaming, certainly highlighting and shaming people who haven't followed the COVID rules. And I think there is an instinct, unfortunately, in this individualist society that we live in to want to apportion individualistic blame to something that's actually a public health issue, and whether the reasons behind it are much larger than any one individual. And so we have to move beyond blame. And I would say some of the policies that I'm sure you're also that are still incomplete that would actually help end the epidemic in Australia would, ensuring that there is full access to healthcare for everybody, including migrants, including undocumented migrants, ending the compulsory HIV testing with these spitting laws, making sure that that sex work and drug use are not only decriminalized but actually legalized, and then lowering the threshold for testing and HIV services for everybody. So those are the policy things that and I'm sure that you're all working towards those. And I'm worried, just as HIV criminalization is a distraction, unless there is extremely good education and community engagement with molecular epidemiology for public health use, it could also be a distraction from actually the bigger issues that I've just highlighted.
Yeah, that's a good point, Edwin. And I think, Simon, you can probably respond to that, because you're heading up an organisation that does a lot of that work, and you're a partner also in this piece of work with Fidelity going forward. So I guess my question to you is, and what you said, Edwin, earlier around, everyone's on the same page here. I think everybody wants to go, are there extra tools in the tool belt that will help us in the HIV epidemic? What are they? How can we apply them? We're not Luddites. We want to use modern technologies. We just got to do it correctly. And I think the fact that we're all here having this discussion and in a very open way is very positive, in the sense that open discussion is going to happen and is happening in this context. But Simon, I mean, there are a lot of people in the community who probably want to know more about this, to be more engaged. Thorn Harbour Health is a partner on this grant, and I know Sharon and Deb and researchers like them, they want community engagement. They want the voice of community to be meaningful in helping them to do this science the right way, so that they're not just out there doing it, but they're doing it with community and with that meaningful input the whole way through. How can the constituents of Thorn Harbour Health, of community affected by HIV, learn more, get involved, work with this grant, with Deb, with Sharon, with others? What's the next steps?
Yep. So this is the final in 5 research forums. So we've run over the last 10 weeks, which, Chad, thank you, you've hosted all 5 of them. And as we said, Sharon's been on more than half of them, so thank you for that. And we had 2 goals in setting up these research forums, 2 key projects. The Alfred Health has approached us, ourselves and Living Positive Victoria and Positive Women Victoria, wanting us to set up a community advisory board that would work as a standing board for HIV researchers, to help them develop research, see what the community want researched, to find out whether their research is acceptable to the community. And so we're hoping to develop an interest group who might be prepared to go that next step and form part of that independent advisory board. And then there's a second project, which was an idea of Deb's that she put forward, about establishing a citizens jury, and that we will be working on with Living Positive and Positive Women Victoria to try and document the community's views, specifically around this issue that we've discussed tonight, so that we can help inform the project that the Doherty's putting forward. So anyone who's registered, we actually do have your contact details, and we will contact you and see if you want to participate. I am aware, I've been watching Facebook, there's been about a dozen or 15 people who've been watching on Facebook, at least on the page I was looking at. And if you want to participate, please email us at events@thornharbour.org, and we will make sure that those invites go out to people. But we are very, very, very keen to get the community more involved in the sort of research that's going on. It helps the researchers, but it also helps us, create research that's valuable to us as well.
Excellent. And it's great to see that partnership with all those partners that you guys have brought into this project, Deb and Sharon. And I want to thank everybody. I guess we're out of time. I want to thank the excellent panel for your insights, the discussion this evening. It's such an important topic. It's actually quite exciting. Let's hope you can get answers to those hypotheses that you've put forward, Deb, and that the answer is that it actually does make a difference in people's lives, and does make a difference in stopping transmissions, and helps us all get to that goal that we're looking for, to make a bigger difference in terms of how we address HIV here. Edwin, thanks for joining us from the other side of the world and providing your wisdom and insights to the discussion as well. As Sharon said, this is not the first discussion. They've been ongoing for a while, and they will continue as this piece of work moves forward. This is just one piece in that puzzle. There's a lot to be discussed, a lot to be analysed, a lot of questions that collectively we can find answers for as community members and as researchers.
And Edwin, your paper that you'll be releasing, we will share that when you get it published in a month or so.
Yeah, thank you. Yes, it'll be on the HIV Justice Network's website, but of course I'll make sure that you get it. You can distribute it across Victoria and Australia.
And you also have a webinar, don't you, that you publish as part of HIV Justice Network?
Yes, well, so actually it's almost a year ago now. We actually we have a web show called HIV Justice Live, and the first subject of that, which was last September, we did a show called "Whose Blood Is It Anyway?", where we actually looked at this, and quite a lot of the work that I've quoted and talked about today was the people who were involved in that. Including Larissa Mulker from Brighton and Alex McClelland and Nana Khanna from the US and Canada who've been involved in this paper. And that's available to watch on our YouTube channel.
And so we will share that through our social media as well.
Thanks everyone, we're out of time. There are a few questions there in the Q&A. I'm sure Mariette on our behalf will take a screenshot of those and be able to get back to the panelists, participants who provided those questions. Thanks Deb, thanks Edwin, Sharon, Simon, and thank you Thorn Harbour Health for giving me the opportunity to chair these 5 forums. I've had a good time, it's been fun, and may you all enjoy your evening or your day in Europe, Edwin. Thank you very much.
Thank you, everyone.
Thank you.
Bye.
Bye.